Howdy YouTube family, it's Bolt CRNA coming to you again with another day's topic. So today we're going to be talking about what skills you have as an RN or that you're growing as an RN that you're going to need as a CRNA or in the anesthesia world. So let's get into it. I bet a lot of you guys did not realize that some of the skills that you're going through as an RN now, trying to get better at and hone your skills, those are things that you're going to actually need as a CRNA. And that means those of you who are wanting to become CRNAs but working as RNs right now, you can already start doing things that are going to enhance your ability as a CRNA and develop a skill that you're also going to have to develop as a CRNA. So you're getting a jump start on it when you're an RN and getting the experience started now, so you're going to be much better at those things when you're in CRNA school. The first one is a little bit of a curveball. You probably are not expecting this, but putting in an orogastric tube, or an OG tube as we call it, is actually something you're going to do quite often as a CRNA or anesthesia provider. Sometimes you'll put in an NG tube instead of an OG tube, which just means you go in with the tube through the nose instead of the mouth. But most often, for our purposes in anesthesia, you're going to be doing an OG tube because it's going to be temporary. It's going to be just throughout the procedure. Then you're going to pull it back out and before you extubate the patient. So for those of you who aren't very knowledgeable about these yet, or maybe you're in nursing school and you've not done a lot of NG or OG tubes yet, what this is essentially a tube that goes either from your nose down to your stomach, which is called a nasogastric tube or an NG tube, or it can go from your mouth down towards your stomach, and that's called an orogastric tube. Now, of course, if you're going to be placing an orogastric tube, the patient's probably going to have to be sedated, unconscious, intubated. Those are typically the situations people are going to be in if you put an OG tube in. And you, of course, can't leave the OG tube in when they're awake, because then they're going to constantly gag on it and choke on it. So if you're talking about for an awake patient, you're going to be doing an NG tube, and that can stay in an awake patient for, days. But in anesthesia, most of the time our patients are not awake, they're asleep, and they're going to be staying asleep throughout the procedure, and we're going to have an ET tube in, an endotracheal tube controlling their breathing. So it makes more sense for us to put an OG tube in. It's a little easier, a little less trauma than the potential that you have with NG tubes. While you're a nurse, go ahead and start getting that skill down. You're going to have a lot of intubated patients. You're going to have a lot of opportunities to put in OG tubes. So go ahead and start trying to get a feel for that. It actually is harder to me as an anesthesia provider to put an OG tube in than it was as a nurse, because when they were in the ICU, I could sit them up, I could face a certain direction, I could manipulate them around, I could do what I needed to do to get really good access to their airway and to positioning the way that I want them to be, so the OG tube goes down smoothly. And I usually had a very good view of what I was doing. Whereas in the operating room, oftentimes, almost always, the patient will be laying flat. So they're going to be laying on their back flat, and they're also probably going to have an endotracheal tube down. So it's a lot trickier than you would think, trying to go in from them laying flat with an endotracheal tube in your way, and maybe a temp probe and other things that you may have in their mouth. And so now you're trying to do this, and a lot of times the surgeon's doing things, they're manipulating the patient around, they're positioning the patient. You don't have the patient all to yourself at this point, so you can't just position the patient sitting up or doing whatever you need to do that helps you get the OG tube in easier. You kind of have to do it the way that they want you to do it, especially if it's in the middle of the procedure and they decide they want you to drop an OG tube down when they didn't need one initially, they thought. And so now you're in a dark room under the drapes trying to get this to go in and trying to get it to the correct place. So not like it's an impossible task, but I will say I have struggled more getting an OG tube to go to the correct place and to not curl in the back of the throat more often as a CRNA than I ever did as an RN placing them. So go ahead, get your experience now, try and do it. If you're doing in the ICU, go ahead and lay them flat and see what it's like to put it in them from the head of the bed, laying them down flat, and get a feel for how that's going to be. Another important skill, maybe arguably the most important skill, is line access as an anesthesia provider. So that's going to primarily mean peripheral IV access, more advanced line access as well, but you're not going to be doing that as an RN, you're going to be doing the peripheral line access. So we're going to start just talking about getting good peripheral IV skills. I know this is difficult Even as an ICU nurse, people think you can do all the more advanced skills, but in reality, you lose a lot of your skill in peripheral IV insertion in the ICU because most of your patients have central lines. Most of them have PICC lines, central lines, something like that, or you're going to get them from the ED and they're going to have 2 or 3 lines thrown in from the ED already. So you may not even need to put a line in them, and by the time those 3 peripherals start going bad, you've probably put a central line in the patient if they're still critically ill. Because most of your patients are going to be on long-term sedation, pressors, meds that are toxic or caustic to the veins. So it's important to have like a more advanced line than just a peripheral line. So most often ICU nurses are not going to be the best at putting in IVs because you don't often put IVs in most ICUs. So it's a rude awakening when you start CRNA school and you suddenly realize I have to get very good at putting in peripheral IVs into a large assortment of different types of patients, end-stage renal disease patients, patients with heart failure and swelling throughout their body, all kinds of different complicated patients who have difficult sticks. You're going to have people who, of course, they've had no fluids or any food in the last 8 or 10, maybe 12 hours, and they've been NPO for surgery, so they're more dehydrated. They're coming to you with flat vessels, flat veins. You're going to have little 90-year-old ladies with little squiggly, tiny veins that wiggle and roll, and everybody's going to be looking to you, out of everyone in the hospital, to get this IV. They're going to be looking to you and expecting you to get it when nobody else can. So I urge you guys, while you're still a nurse working in the ICU, get your experience on IVs. Do lots of them. Try different difficult patients. Anytime someone on the unit needs an IV, offer to go try over there. Try different techniques. Learn from the other nurses, the nurses who have been around 20, 30 years and have learned a lot of different techniques and methods to get IVs in difficult situations. Ask them about their tips, using hot packs, or, there's all kinds of ways that people will teach you little tricks of how to get an IV inserted. But one thing that I hear often from new students starting CRNA school is they're concerned about clinicals because they know they're going to be expected to throw in IVs left and right on all these patients coming in the morning for surgery, and they're concerned that they may not be that amazing at skills for the IV insertions, and they're worried that they'll, may get yelled at or may be looked at as being incompetent for clinicals. Get your experience now as an RN. Try and hammer down that skill. Get really good at it. You'll be amazed at how difficult some of the IV sticks are going to be when you get into anesthesia, and especially when you get out of school, and people really will call on you to be the one person in the whole team who knows how to get an IV in a difficult patient. They'll call you, and the patients will even, there have been situations I've had in my first year as a CRNA where the patient refuses to even allow anyone to stick them for an IV except for me. They want anesthesia to come stick them. Not me personally, I just mean they declare anesthesia is the only one who's ever able to get an IV in me at any hospital I go to. 10 other people stick me, and then anesthesia comes and has to do it. So I just want anesthesia to come and do it. So that's a lot of pressure on you to be like the guy who has to show up when everyone else is being told they can't try. And then you've got to try, and then if you miss a bunch of times, it looks bad, and the patient, is still needing access, and you're still not able to get it. So those are situations that do come up in the anesthesia world. I recommend trying as much opportunities as you can to get IV insertions while you're still a nurse. And side note, do not get really good at putting in 22s and 20 gauge IVs. A 20 gauge IV is bare minimum for most cases. We want at least one good 20 gauge for a healthy patient that we're not going to tuck the arms on. You don't want to go into the anesthesia world saying the most I ever have been able to get is a 20 gauge in somebody. Really, you want to be good at putting in 18s and 16 gauges. 16 gauges are not totally necessary unless you're planning to do blood or you think that it's going to be a more advanced patient, but there have been moments in my anesthesia career where I've said, I probably need to get a 16 gauge in this person. Go ahead, if you have a patient in the ICU who needs a larger gauge IV and you need to get that experience in, try that. You don't want to start anesthesia training without really knowing how to do anything larger than a 20 gauge. When I did one rotation in school, my cardiac rotation, they told us there's nothing smaller than an 18 gauge that gets put in these patients. Don't even try 20 gauge. We want 18 gauges or 16 gauges on all of our patients. So you had to get really good at throwing in 18 gauges. So that's just a good recommendation for anesthesia in general. Another thing that you guys do as nurses in the ICU is cardiac and pulmonary assessment. You're already pretty good at that, I would guess, but try and really hone your skills at it. If you've been kind of glossing over your respiratory assessments and your cardiac assessments and you've just been phoning in a little bit, don't do that. Start actually really listening to your heart sounds, really paying attention to the lung sounds, really looking at your vent settings, really looking at what's going on with the respiratory compliance of the patient. If you're a respiratory therapist and the pulmonologist are making a bunch of vent changes, ask them about what they're doing. And like, hey, what's the theory? What's the thought process behind what the lungs are doing here? Is this ARDS? What does that mean physiologically for my patient? How does that present with oxygenation? Ask these questions. Talk about PEEP. Ask them about what the PEEP setting is doing and what's it doing for your patient. Start trying to understand more when you're doing your pulmonary and cardiac assessment. Start understanding more the physiology behind what you're assessing and what's going on, and if there are changes, why you're noticing these changes, because that's going to help you out a lot when you start anesthesia, because at that point you have to make these assessments and then make the changes on your own and make decisions and critical thinking decisions and treatment plans based off of your assessments. So it becomes vitally important that you are good at assessing these things, good at noticing these things. Another thing you guys are already doing in ICU is titrating meds. That is a great skill to get good at. You should not be mindlessly titrating meds to protocols. You should be thinking critically about, why are you going up on the sedation? What does it mean for the patient? How does this medicine act in the body, and how much does it build up? You should be thinking about the drugs that you're infusing. What's the mechanism of action of these drugs? You should be thinking about your titrating of your vasopressors. So if you're titrating up your neo drip, why does the heart rate go lower? Like, what's happening there physiologically to make that happen? You should be thinking about dopamine and why the heart rate's going up, and all these kind of things. When you're titrating different meds and you're doing different things on your patient, making these decisions that you're trained as an ICU nurse to do, you should be thinking deeper about why you're doing them, because when you go into the anesthesia world, you're going to blow the top off all the information, and you're going to be expected to know everything to the nth degree, to the cellular micro level of what's going on with these drugs and where they're acting in the body and how things are transpiring from this action to this action to this action. And then you go into your anesthesia rotations and you'll be asked and be what's called pimped on these types of questions fairly often. So if you go ahead and start getting a base level of knowledge of this and start getting your mind wrapped around thinking about this stuff while you're in the ICU still, it's going to help you out a lot later on when it's time to go into anesthesia school. And lastly, I would tell you guys, when you're looking at vital signs and you're seeing a trend, start trying to piece together why you're seeing that trend. If you're noticing that the blood pressure keeps getting up higher and higher and higher, or the heart rate's getting lower, or you're having a lot of changes in the respiratory rates and things like that, start thinking about why. Start thinking about, is it pain? Is this heart rate going up because of a fever? Start trying to really critically assess why your vital signs are trending in certain directions and what you can do to intervene in those things. You already kind of do that as an ICU nurse, or you should be doing that as an ICU nurse. But I would just ask that you take it even deeper, to a deeper level. There's some times where we kind of, as an ICU nurse, you would say, that's just the blood pressure just going up or going down. I'll titrate this med and help fix it. And we think about our immediate treatment to fix it, but maybe you didn't think about why it's exactly happening and what you could maybe do at the root cause to fix that. Because that's how you're going to be treating things as a CRNA. When you see things changing, and what you do in a static case is you're very vigilantly, constantly watching every heart rate, blood pressure, oxygenation level, temperature level. You're watching all of these things that's going on with the body, including the ventilator's signs and things like that. And you're making critical decisions on, is this happening because the surgeon's doing this? Is this happening because of a medication I gave? Is this happening because of pain response? And you're having to think these things through and then immediately treat them very quickly and try and head things off before it trends into a dangerous path. So if you start getting good at analyzing those things while you're still in the ICU working as a nurse, it's going to really get your mindset wrapped up around that and get you ready for that kind of thinking when you start anesthesia, and it takes it to a much more critical level. Well, all right, guys, that was all of our tips and tricks about what you can be doing in the ICU to help you prepare for going to CRNA school. A lot of you guys hit me up and you're so eager to get into CRNA school, and I remember because I was too. I was really eager and ready to get in and ready to be done with ICU and ready to go on to anesthesia training. But the truth is there's tons of stuff as a critical care nurse that you can be doing to prep yourself and ready yourself and make yourself an even better anesthesia student when you get to that place. So while you're spending those couple years getting your ICU experience, remember there's a reason why that experience is required. It's not just some dumb rule they made up that they just want you to do. There's a reason why they want you to have a few years of ICU experience. So use that time to hone those skills, develop them, and you're gonna be a lot better off in anesthesia school when you get started. Hit me up in the comments below if I missed out on anything or there's any other skills that you guys can think of that you do in the ICU that's gonna help you out in anesthesia. Follow me on Instagram, of course, it's Bolt CRNA over there. You can also join the channel membership. I'm really excited about this new channel membership we're doing now. I really like connecting with you guys. I offer mentorship, I offer study guides and stuff for people trying to interview for CRNA school and get in. And I also offer exclusive videos over there and live chats and stuff. So go over to the community page, join the channel membership, and that's Bolt out.